Hello, I'm Akshay Desai, a physician in the cardiovascular division at Brigham and Women's Hospital in Boston, Massachusetts, and associate professor of medicine at Harvard Medical School. This talk is about tricuspid and pulmonary valve disease. I've put pulmonary valve disease in parentheses because it's a relatively uncommon cause of clinical pathology in adults with heart disease. These are my disclosures. Let's begin with an anatomic review of the anatomy of the valve plane. You can see that the tricuspid valve is a posterior structure with 3 leaflets, while the pulmonary valve is the most anterior structure in the heart, again, a 3-leaflet valve. Focusing on the tricuspid valve, you can see that the annulus has a semi-lunar shape, and the valve is composed of 3 leaflets, a septal leaflet marked E, an anterior leaflet marked A, and a posterior leaflet marked B. These are anchored by chordae tendineae to 3 papillary muscles that support each of the leaflets. The attachments of the septal leaflet via the chordae are to the septal papillary muscle, and this means that the septal leaflet is tethered in some sense to the septum. And in the context of right ventricular enlargement, this is the anatomic reason that functional tricuspid valve regurgitation develops. The proximity of the annulus to the AV node is one explanation for why, as the tricuspid valve is involved with inflammatory pathology, there's occasionally risk for heart block. And the size of the tricuspid annulus, as you can see, is about 20% larger than the mitral annulus. This is important as a consideration in selection of surgical prostheses. In 3 dimensions, the tricuspid annulus is shaped like a saddle, and this non-planar shape is important for maintaining the integrity of tricuspid valve function. The shape is also critically important in considering surgical repair of severe tricuspid regurgitation because specifically shaped annular prostheses are necessary for successful repair and or replacement. Note that the superior points of the tricuspid annulus are anterior, and the posterior ones, as are the posterior ones, and the septal and lateral points are inferior towards the right ventricle. And this will come back to as we think about the pathogenesis of functional tricuspid regurgitation. When we think about tricuspid regurgitation in adults with heart disease, there are 2 general pathologies. The first is functional tricuspid regurgitation, and we give this categorization when patients have structurally or morphologically normal leaflets, and the pathology is really the pathology of the annulus. This is related either to primary problems with tricuspid valve annular dilation, which might happen in patients with right ventricular failure and resultant RV enlargement, patients with atrial septal defects, those with anomalous pulmonary venous return, both of which might provoke right ventricular enlargement, and might also happen in the setting of prolonged or chronic atrial fibrillation. Another important pathology that might relate to functional tricuspid regurgitation is pulmonary hypertension, because high pulmonary pressures create increased right ventricular systolic pressures and may promote right ventricular dilation as well. The second type of pathology related to tricuspid regurgitations are primary structural abnormalities of the tricuspid valve. These fit into 2 broad categories. First is congenital heart disease, and the second are acquired diseases, more commonly seen in adults. Amongst the congenital abnormalities, the chief abnormality to be aware of is Epstein anomaly, which we'll come back to a bit later. And then there are a few less common abnormalities, including hypoplasia of the tricuspid valve or dysplasia of the tricuspid valve, or a cleft tricuspid valve. Acquired abnormalities of the tricuspid valve include those related to infection or inflammation, as mentioned on the first slide. Endocarditis is a common cause of tricuspid valve disease in the adult and is particularly prevalent amongst those who use intravenous drugs. Injection drug users are at higher risk for right-sided endocarditis of all types because the venous circulation and any debris or bacteria that are introduced during injection are immediately exposed and preferentially exposed to the right side of the heart and less so to the left side due to the filtering by the lungs and the pulmonary circulation. Trauma is another potential contributor to structural tricuspid valve disease. Carcinoid heart disease is another specific example that affects both the tricuspid and occasionally the pulmonic valve that we'll come back to. Rheumatic heart disease is increasingly rare in Western communities because of effective treatment of streptococcal infection, but is a contributor to the development of both tricuspid regurgitation and stenosis, as well as some variants of pulmonic valve disease. Myxomatous mitral valve or tricuspid valve degeneration is a cause of tricuspid valve prolapse or flail, and may be seen with or without myxomatous degeneration of other valves. And then there are some iatrogenic causes. Chief among these is previous radiation to the chest, which might affect any of the heart valves, but the tricuspid valve in particular, as well as some drugs, particularly weight loss drugs like phentermine, dexphenfluramine, which might affect the tricuspid valve. There are iatrogenic causes related to repetitive endomyocardial biopsy. We frequently see this, for example, in patients post-cardiac transplant. And then, importantly, if patients have indwelling cardiac rhythm devices that traverse, with leads that traverse the tricuspid valve, tethering of the tricuspid valve leaflet or some adherence of the lead to the tricuspid valve leaflet may result in significant iatrogenic tricuspid valve regurgitation. So I think broadly speaking, when one sees a patient with functional TR, there should be some consideration of three broad etiologies. One is primary pulmonary disease that might generate pulmonary hypertension, or primary pulmonary arterial hypertension that might generate right ventricular dilation dysfunction, tricuspid leaflet tethering, and then functional TR. Left heart disease, including left heart disease from coronary disease, other causes of systolic dysfunction like primary cardiomyopathies or mitral valve diseases such as mitral regurgitation or mitral stenosis that generate rises in left atrial pressure, and either secondary pulmonary hypertension or left atrial dilation that promotes atrial fibrillation. In the case of chronic atrial fibrillation, we see dilation of both the mitral and tricuspid annulus, and this might cause functional TR, and this might be compounded by the development of pulmonary hypertension, because chronically elevated right-sided pressures may generate right ventricular dilation dysfunction. Tricuspid leaflet tethering, particularly tethering of that septal leaflet, as the RV enlarges, may result in enlargement of the annulus and poor coaptation of the tricuspid valve and functional TR. And then independent of both left heart disease and pulmonary hypertension, longstanding atrial fibrillation may contribute to pathogenesis of tricuspid regurgitation as a consequence of atrial remodeling and resultant annular dilation. We've talked a bit about the way in which functional tricuspid regurgitation develops as a consequence of right ventricular enlargement, but I think anatomically these diagrams are useful in understanding why this happens. Recall that if this is a patient with a normal tricuspid valve, the septal leaflet is anchored to the septum, so that when the free wall of the right ventricle enlarges, the saddle shape of the tricuspid valve becomes more flat and circular. As this happens, the free wall causes enlargement of the right ventricle, and particularly distortion of the free wall causes progressive distortion of the annulus. And because the septal leaflet is tethered while the other leaflets are not, there's resultant incomplete coaptation of the valve and resultant significant tricuspid valve regurgitation. So functional TR proceeds as the consequence of distortion of both a three-dimensional shape and the annular enlargement that happens in patients with right ventricular enlargement. Symptoms of tricuspid regurgitation are prevalent only after a long latent period. Patients with severe tricuspid valve regurgitation may have no symptoms because TR is very well tolerated often for a long period of time. But eventually, principally due to effects of the significant regurgitant volume on right ventricular remodeling, patients and function. Patients exhibit symptoms of fatigue and effort intolerance, eventually symptoms of hepatic congestion that may result in hepatomegaly, capsular stretch, and then right upper quadrant pain. In patients with significant right heart failure, there may also be evidence of diminished appetite and abdominal fullness or ascites. And patients may also have evidence of peripheral edema and anasarca. The presence of all of these indicates profound right heart failure and should initiate some consideration of whether there is a need to intervene to manage tricuspid valve regurgitation. On physical examination, the vast majority of patients with tricuspid regurgitation have visible distension of the jugular veins. The morphology of the jugular venous waveform is also important, and in patients with severe TR, there should be a prominent V wave that tracks with systole that indicates the change in pressure in the right atrium with regurgitant volume. 90% of patients with significant tricuspid regurgitation have some degree of hepatomegaly that should be discernible on exam. And classically, these patients have a pulsatile liver, that is the volume, the regurgitant flow is palpable on hepatic exam as a systolic pulsation, but in truth, this is relatively infrequent and it's not a very sensitive sign for tricuspid regurgitation. On a cardiac auscultation, TR is typically classified as a holosystolic murmur audible at the right lower or left lower sternal edge that increases in intensity with inspiration. Realize that patients with severe TR may have a softer or inaudible murmur due to rapid equalization of right ventricular and right atrial pressures, which means there's not much of a gradient and there's limited turbulence. Another way to assess TR is through echocardiography. And in general, the point of echocardiography in patients with tricuspid valve disease is to get at the primary etiology of the disease, to differentiate primary leaflet pathology from functional tricuspid regurgitation, and to estimate the severity of disease. With regard to etiology, things to look out for are evidence of vegetations, evidence of leaflet pathology, including leaflet thickening or retraction that might suggest primary disease of the leaflets, evidence of tricuspid leaflet prolapse or flail, and patients with tricuspid valve distortion or dysplasia that may suggest the presence of congenital disease. And important also to look for associated congenital anomalies that might be present in patients with more expansive cardiac syndromes that involve the tricuspid valve. In any patient with tricuspid valve disease, it's important to assess the severity of tricuspid regurgitation as well as the pulmonary artery pressure, since pulmonary hypertension is an important contributor. It's important also, since this is an important feature for differentiating those who require surgery, to assess the state of the right ventricle by formally assessing right ventricular dimensions and function. And as I mentioned, to look at associated lesions that may be present, since tricuspid valve disease often does not happen in isolation. On Doppler examination by echocardiography, the figure here depicts patients with mild, moderate, and severe tricuspid regurgitation, as well as a patient with massive tricuspid regurgitation, with the continuous wave Dopplers and the Doppler of the mitral and the pulse wave Doppler of the mitral inflow. On the color flow images, you see that patients with severe tricuspid regurgitation have a large color flow area that is during systole. Using PISA methods, we can define an effective regurgitant orifice area, and a value greater than 40 is considered consistent with severe TR. Regurgitant volume that is greater than 45 defines severe TR, and a vena contracta width measured right at the annulus greater than 7 is consistent with severe TR. So these are the numbers to keep in mind. Patients with severe TR on continuous wave Doppler have a truncated, intense tricuspid valve envelope that is triangular in shape and has a sharper peak than the more sort of rounded peak of patients with mild tricuspid regurgitation. And on tricuspid valve inflow views, we see that there is an elevated E velocity, and E velocity approaching a meter per second or exceeding that is consistent with severe TR. Another feature that is thought to be relatively specific for significant tricuspid regurgitation is flow reversal in the hepatic veins. And if you see the hepatic vein here, you can see that during systole, there's evidence of regurgitant flow within the hepatic veins. That should not be present. And it's again shown here in the color M mode. Recall that flow should not be present in this direction during systole. Blunting of systolic or hepatic venous flow can occur with right atrial pressures or atrial fibrillation, but this flow reversal during systole is quite specific for severe TR. Realize that it may be less apparent in patients with, who are in atrial fibrillation at the time of hepatic venous Doppler assessment. Patients with tricuspid regurgitation that is severe do have worse prognosis than those who are mild, and you can see that there's a graded relationship between tricuspid regurgitation severity and survival. This curve, which reflects prognosis related to patients without TR, those with mild TR, those with moderate, and those with severe tricuspid regurgitation in about 5,000 patients from the VA healthcare system in Palo Alto, highlights that the worse the amount of quantitative tricuspid regurgitation, the worse that patients' survival is, regardless of left ventricular ejection fraction or pulmonary pressure, and independent of factors like age, biventricular systolic function, and right ventricular size. Patients with flail leaflet who represent one specific etiology of tricuspid regurgitation and one related to structural valve disease are particularly amenable to tricuspid valve repair. These data depict the 60 patients from a single center and highlight the natural history after severe tricuspid regurgitation caused by a flail leaflet. In these patients with isolated tricuspid valve disease, you can see that the incidence of new atrial fibrillation is about 3% yearly. The incidence of heart failure is about 4% yearly. And the composite incidence of the first occurrence of heart failure, new atrial fibrillation, tricuspid valve surgery, or death is about 6.5% yearly. But I think these data highlight the long latency period, since it's really about 6 or 7 years before more than half of the patients come to some sort of symptoms or the need for surgery. And this is a circumstance in which there may be longstanding severe tricuspid valve regurgitation. So the question then becomes how to manage patients with tricuspid valve regurgitation. And the first approach is treatment of reversible causes. So patients with pacemaker leads that may be causing entrapment of the tricuspid valve should be considered for device revision. Patients with significant pulmonary hypertension should undergo therapy to reduce the pulmonary artery pressures. And if that pulmonary hypertension is related to left heart disease, then intervention to manage the left heart disease would be appropriate, for example, in patients with heart failure. Next is to optimize right ventricular function, and if there is significant right ventricular enlargement or congestion, treatment with diuretics would be appropriate to relieve those symptoms, because as mentioned, tricuspid regurgitation can be very dynamic since the RV size is very sensitive to the filling volume, and over time, if the filling volume can be reduced and the distortion of the RV can be reduced, the septal and anterior leaflets may be brought in closer apposition and the functional TR may be reduced. Sodium restriction also has a general role in management of right heart failure, particularly in patients with more advanced disease. Tricuspid valve surgery is really the only demonstrated effective therapy for severe TR, since medical therapy may modify symptoms but doesn't clearly modify the progression of right ventricular dysfunction, except perhaps in the case of pulmonary hypertension. So what are the indications for tricuspid valve surgery in the setting of tricuspid regurgitation? Well, there are two class 1 indications by the guidelines. The first is that if patients are already in the operating room undergoing left-sided valve surgery, for example, to remedy aortic or mitral pathology, tricuspid valve surgery is indicated if patients have severe tricuspid regurgitation. The tricuspid valve surgery should also be considered if there is moderate primary tricuspid valve regurgitation or mild to moderate functional or secondary tricuspid regurgitation if there is significant annular dilation, and that's defined as more than 40 millimeters. The point being that if patients are getting a left heart surgery and there's at least moderate primary TR or mild to moderate secondary TR, even mild secondary TR, and the annulus is large, there's a high risk of recurrent TR after surgery, and patients should be therefore intervened at the same time that they're getting left heart surgery. Isolated tricuspid valve surgery is a much more difficult thing to consider, but should be considered in patients with severe primary tricuspid valve regurgitation if patients have symptoms, or in asymptomatic patients with progressive right ventricular enlargement or initial RV dysfunction. So when there is incipient right ventricular failure, even in asymptomatic patients, we should consider it, and anybody with severe primary tricuspid valve disease in which symptoms are present should be considered. So here's a flow diagram. If the patient is going to the operating room for mitral valve surgery, then if they have severe tricuspid valve disease, again, they should go for tricuspid valve surgery. If they do not, but there is annular dilation or moderate TR related to a primary tricuspid valve problem or significant pulmonary hypertension, these are circumstances where it's worth considering fixing the tricuspid valve as well. If the patient is not undergoing mitral valve surgery, we're in the pathway for primary repair of tricuspid valve disease, and this is appropriate only in the presence of symptoms, no surgery. If there are no congestive signs or symptoms and there is severe TR, watchful waiting is appropriate. If there is no major comorbidity, tricuspid valve surgery may be appropriate, but medical therapy is probably appropriate if there's major comorbidity that heightens the risk of tricuspid valve intervention. So patients with isolated tricuspid valve disease present a challenging clinical management problem and a need to balance the risks and benefits of surgical intervention. A question that often comes up is whether to repair or replace the tricuspid valve once the decision for surgery has been made. This is a series of 250 patients from a single center with primary tricuspid valve disease. Tricuspid valve repair in this series, which is depicted in the solid line, was associated with better perioperative, midterm, and event-free survival than tricuspid valve replacement. Despite more tricuspid valve regurgitation in the patients who were repaired during follow-up, the reoperation rates and functional class for the two approaches were similar, and this girds the preference for repair whenever it's possible in patients with primary tricuspid valve disease. When repairing the tricuspid valve, there are two general approaches that have been taken. One is called a purse string annuloplasty that is depicted in this figure. The second approach is with a ring. In general, purse string is used in combination with left-sided valve replacement in patients who have functional tricuspid regurgitation without pulmonary hypertension, and the ringed annuloplasty is generally preferred when the main operative indication is tricuspid regurgitation and only mild to moderate pulmonary hypertension is present. In general, tricuspid valve repair with a ring is associated with better long-term outcomes and better long-term freedom from recurrent tricuspid valve regurgitation compared with simple purse string annuloplasty alone. Tricuspid valve replacement is indicated for patients with symptomatic tricuspid regurgitation and significant pulmonary hypertension, or those whose valves are not structurally suitable for tricuspid valve repair. The durability of right-sided bioprostheses is generally greater than those on the left because it is a lower pressure circuit, and accordingly there's no difference in survival between patients receiving a bioprosthesis and a mechanical prosthesis. We generally don't use pericardial valves in the tricuspid valve position because of increased leaflet stiffness and risk for obstruction. And so in general, the choice is for a bioprosthesis unless patients have a clear indication, such as atrial fibrillation for chronic anticoagulation, in which case a mechanical prosthesis is selected. There are a few specific examples of pathology associated with valvular heart disease that you should be aware of for board review. The first is a congenital abnormality called Epstein anomaly. Epstein anomaly is characterized by apical displacement from the annulus of both the septal and the posterior leaflets of the tricuspid valve. This generates an enlarged right atrium that includes the atrialized portion of the right ventricle that's created by this apical displacement of the tricuspid valve leaflets. This is almost invariably associated with severe tricuspid regurgitation, and that is apparent on physical exam. On this is the pathologic specimen of a patient with Epstein anomaly that shows you that a atrialized portion of the right ventricle and the marked right ventricular enlargement. On echocardiography, you can see this image and the typical apical displacement of the tricuspid valve leaflets. And you can also detect associated anomalies that are commonly seen, including a patent foramen ovale or an atrial septal defect. On the electrocardiogram, look out for unusual P waves, right bundle branch block, and pre-excitation to highlight this, because patients with Epstein anomaly frequently have evidence of pre-excitation in Wolff-Parkinson-White syndrome. This condition has been associated with maternal lithium exposure, but can also develop in the setting in the absence of such exposures. Another specific example of tricuspid valve disease associated with tricuspid regurgitation is carcinoid heart disease. As you'll recall, carcinoid heart disease develops in the setting of neuroendocrine tumors that secrete serotonin metabolites. These might present with flushing, diarrhea, and other gastrointestinal symptoms if there's abdominal involvement. But patients with carcinoid frequently develop tricuspid and other right-sided heart and pulmonic valve disease. The pathologic image depicts a patient who has septal involvement by carcinoid. You can see the marked thickening of the leaflet and retraction of the leaflet that's characteristic of carcinoid heart disease. On the two-dimensional echo RV inflow view, the arrows heads mark the thickened and retracted septal and anterior leaflets of the tricuspid valve, as well as marked enlargement of the right atrium and right ventricle. And this color flow image shows the image of severe tricuspid regurgitation that you would expect due to poor leaflet coaptation in this setting. Carcinoid heart disease that affects the tricuspid valve is best treated surgically with valve replacement because valve replacement in this condition improves survival. And as you can see on this data from Dr. Muller, the indications predominantly grow out of the observations about the natural history of the disease in patients with minimal RV dilation and no heart failure or minimal tricuspid regurgitation. There appears to be generally good survival compared with those in whom the amount of RV enlargement or dysfunction or the severity of right heart failure is more significant. Accordingly, in patients with worsening symptoms, and particularly those with progressive right heart failure in the setting of severe tricuspid regurgitation and carcinoid heart disease, replacement is considered. Patients with carcinoid disease and who get a bioprosthesis might be at risk for development of recurrent problems with the bioprosthesis if the tumor is not effectively suppressed. But if the carcinoid is actively treated, then bioprostheses may be appropriate. A note of caution, there is risk for significant hemodynamic lability with significant peripheral vasodilation and hypotension perioperatively during tricuspid valve replacement for this condition, and this can be managed with expeditious administration of octreotide to suppress production of the serotonin metabolites. A final comment about tricuspid regurgitation is TR that occurs after left-sided valve surgery. We already mentioned the indications for repair of the tricuspid valve in the setting of a patient undergoing left-sided valve surgery. And this is driven by the fact that in about a third of patients with mild TR at the time of the initial operation, there is recurrence of tricuspid regurgitation after left heart surgery. Redo surgery can be considered early after the operation with an acceptable early postoperative mortality and significant improvement, but late mortality remains high, particularly in those who are older and have had multiple redos. And this is one of the reasons that we are so aggressive with considering tricuspid valve repair at the time of left-sided valve surgery, particularly if there is annular dilation. We'll shift gears now and talk a bit about less common pathology, including tricuspid stenosis and pulmonic valve disease in adults. Briefly, tricuspid stenosis is extremely rare in the developed world because rheumatic heart disease accounts for nearly 90% of the patients. But in general, amongst patients with rheumatic mitral valve disease, less than 5% develop associated tricuspid valve disease, and it's very uncommon for rheumatic heart disease to affect the tricuspid valve without involvement of the mitral valve. There are congenital abnormalities which can cause tricuspid stenosis. Some right atrial tumors can cause effective functional tricuspid stenosis, such as large myxomas. Carcinoid heart disease, we've mentioned, can be associated with tricuspid regurgitation, but might also cause tricuspid stenosis. Extensive endomyocardial fibrosis might affect the tricuspid valve and limit tricuspid leaflet excursion. Endocarditis and large vegetations may cause significant stenosis, and there are some extracardiac tumors that may contribute. These are a long differential for a fairly rare problem. On physical examination, tricuspid stenosis is identified by an elevated jugular venous pressure with a prominent A wave and a slow Y descent. These are the jugular venous waveforms and the phonocardiograms to sort of help you look through this. And you can see here that the A wave in TS is very prominent as compared to the V wave, which is more pronounced in patients with tricuspid regurgitation. The other issue that's here. In patients with tricuspid stenosis, there is an opening snap, which is the abrupt cessation of opening of the tricuspid valve due to the stenosis, and a diastolic rumble that's audible at the right sternal border and varies with respiration. And you can see that murmur diagrammed here. On echocardiography, analogous to those with mitral valve disease, rheumatic changes include commissural fusion with diastolic doming of the leaflets and thickened, shortened chordae. So the pathology of tricuspid stenosis in the setting of rheumatic heart disease looks a lot like it does in other valves. The findings on Doppler imaging that suggest significant tricuspid stenosis include a mean tricuspid valve pressure gradient more than 5 millimeters of mercury, a pressure half time of more than 190 milliseconds, a valve area that measures less than 1, and supportive findings include an enlarged right atrium and a dilated inferior vena cava. Since in the absence of these things, it's hard to imagine that severe TS is present. The management of severe TS is principally surgical. There's limited role for medical therapy, except perhaps in patients with atrial fibrillation to slow the ventricular rate, as with mitral stenosis, to maximize time for filling. Use of diuretics may be helpful, but is done with caution because the gradient across the tricuspid valve may mean that in the presence of very high right atrial pressures, right ventricular and diastolic pressure is actually quite low. And so this may be a challenging condition to manage with oral therapy. The best treatment, as mentioned, is tricuspid valve replacement. The class 1 indications are severe TS with or without TR in patients who have symptoms despite medical therapy. This is a recurring theme in valvular heart disease, that if there are symptoms, then you might, in the setting of severe disease, you should consider valve surgery. And then in patients who are undergoing left-sided valve intervention who have severe TS, that's another reason to consider surgery. Percutaneous approaches to management of right-sided heart disease are increasingly being preferred and can be done at lesser morbidity than surgery. Balloon valvotomy may be an alternative in selected patients with isolated tricuspid stenosis, but carries with it risks of worsening tricuspid regurgitation, particularly if there's a lot of calcification. Percutaneous tricuspid valve replacement is really an evolving field and is probably outside the realm of things you'll be responsible for on the boards. Let's switch gears for a moment and talk a bit about pulmonary valve regurgitation, pulmonary valve disease. We'll start with pulmonary valve regurgitation. Pathologic pulmonary regurgitation is most commonly the consequence of congenital heart disease interventions. Mild to moderate PR is very frequently seen on echocardiography in adults, and in general it's an incidental finding that doesn't require intervention. Severe pulmonic valve regurgitation is generally uncommon, and as mentioned is related typically to surgery for repair of tetralogy of Fallot or other congenital heart lesions. Secondary pulmonic regurgitation may be a consequence of other pathologies like carcinoid heart disease or long-standing pulmonary hypertension with annular dilation. The recognition of pulmonary valve regurgitation is heralded by the physical exam and auscultation. Patients may have a peristernal lift if the RV is enlarged, and this happens because unremediated pulmonary regurgitation that's significant leads over time to right ventricular dilation and dysfunction. The murmur of PR is sometimes audible, particularly in patients with pulmonary hypertension, and is typically a soft diastolic decrescendo murmur audible at the sternal border. If there's a large volume regurgitation, an associated systolic ejection murmur may also be heard. Increased intensity of the PR, the diastolic component of the murmur, may be heard with inspiration. Detailed analysis of PR severity is probably beyond the scope of what you're likely to be responsible on board examinations, but know that intervention for symptomatic severe PR or asymptomatic severe PR is important if patients have right ventricular dilation or dysfunction. So if there is an RV failure or even in the absence of symptoms, there is a reason to consider pulmonic valve intervention for PR. And in patients who have symptoms associated with PR, there may also be an indication for intervention. For pulmonic valve disease, transcatheter interventions are increasingly an alternative to surgical pulmonic valve replacement for selected patients. And in general, if you have a patient in whom you're considering intervention, referral to a center that has a lot of experience with both surgical and transcatheter approaches, typically an adult congenital heart disease center, would be appropriate. Pulmonic valve stenosis is essentially a congenital disorder. 95% of PS cases are related to congenital or genetic disorders such as Noonan syndrome, which is commonly associated with PS. Most patients who have mild to moderate, there are some rare causes of pulmonic stenosis, including carcinoid heart disease and rheumatic heart disease, in which case other valves are nearly always affected. And as mentioned, there are rare causes such as obstructing vegetations or tumors. Most patients with mild to moderate pulmonic stenosis are asymptomatic, but about 1 in 4 do progress over time to the need for intervention. Patients with severe PS may exhibit fatigue and dyspnea, and systemic or suprasystemic right ventricular pressures in the setting of significant pulmonic stenosis can cause exertional lightheadedness or syncope and eventually right heart failure. The intervention for patients with severe PS is driven by measurement of the gradients and assessment of symptoms and right ventricular function. In general, intervention should be considered for patients who are asymptomatic if there's pulmonic stenosis with a peak gradient greater than 60 or a mean gradient more than 40. If patients are symptomatic with a peak gradient between 50 and 60 or a mean gradient greater than 30, intervention could also be considered. And as mentioned, typically this is percutaneous intervention where possible these days. Athletes who need more physiologic reserve might be referred for intervention at slightly earlier stages, for example, at peak gradients less than 40. And patients who are pregnant with severe PS may also be candidates for interventions at slightly earlier stages. On examination, pulmonic stenosis is typically associated with a pulmonary ejection sound that decreases in intensity with inspiration and an ejection murmur that increases with inspiration. Severe PS may be accompanied by a jugular venous A wave and a right ventricular lift. With increasing PS severity, the ejection click moves closer to the first sound and eventually disappears. S2 becomes widely split and ultimately single, and a right ventricular S4 gallop might be heard. Getting back to management, isolated pulmonic valve disease is typically managed with balloon valvotomy or percutaneous replacement, as mentioned. So in summary, if we think about tricuspid and pulmonic valve pathology, we should remember the following. Tricuspid regurgitation is common and arises primarily from structural abnormalities of the valve leaflets or secondarily from annular dilation and leaflet tethering. Second, surgery for tricuspid valve disease is indicated in patients with severe TR and symptoms or in asymptomatic patients who have progressive RV enlargement or dysfunction, and that's for primary tricuspid valve disease. Functional tricuspid valve regurgitation, on the other hand, might improve with treatment of right ventricular volume overload and pulmonary hypertension, and that's the first-line approach. Surgery can be considered in patients with mild or moderate functional TR at the time of left-sided heart surgery if there's annular dilation more than 40 millimeters. Whenever possible, when approaching tricuspid valve surgery, tricuspid valve repair with a ring annuloplasty is preferred over tricuspid valve replacement, and purse-string suture annuloplasty is generally inferior to ring annuloplasty with regard to durability. Tricuspid stenosis is rarely an isolated entity. Frequently, it's related to rheumatic heart disease, and symptomatic patients with TS are managed with tricuspid valve replacement. Pulmonic valve disease, both pulmonic valve regurgitation and pulmonic stenosis, are relatively rare in adults, at least rare in severe form, and are principally related to complications of congenital heart disease. And with this, we'll move on to a few questions. The first question is, a 56-year-old woman with rheumatic heart disease and symptomatic mitral stenosis has been scheduled for mitral valve replacement. Review of the preoperative echocardiogram confirms a heavily calcified mitral valve with mean gradient of 9, a mitral valve area of 1.2, marked left atrial enlargement, normal biventricular size and function, and mild to moderate tricuspid regurgitation with annular dimension of 35 millimeters. So with that scenario in mind, at the time of mitral valve surgery, which of the following is the best approach to management of her tricuspid regurgitation? Would you consider A, de Vega suture annuloplasty, B, tricuspid ring annuloplasty, C, porcine tricuspid valve replacement, D, mechanical tricuspid valve replacement, or E, no tricuspid valve surgery? The intended answer here is E, no tricuspid valve surgery. To recall, this is a patient who requires mitral valve surgical intervention for symptomatic mitral stenosis related to rheumatic heart disease and has mild to moderate TR, but the annular dimension is only 35 millimeters. So in this setting, the guidelines do not recommend intervention. The threshold for intervention of tricuspid valve regurgitation in the setting of a mitral operation is 40 millimeters. Question number 2. A 65-year-old woman with a history of coronary artery bypass grafting and mitral valve repair 6 years prior presents with progressive shortness of breath. On examination, her blood pressure is 90/60, jugular venous pressure is elevated at 18, the lungs are clear, the cardiac exam reveals a grade 3/6 holosystolic murmur at the right sternal border and an S3 gallop. The liver is palpable 3 finger breaths below the right costal margin and slightly pulsatile. The abdomen is distended, there is 3+ pitting edema. The echo shows a markedly dilated left ventricle with an EF of 35% and inferior hypokinesis, an intact mitral valve repair with moderate central mitral regurgitation, and marked RV cavity dilation with severe TR and flow reversal in the hepatic veins. Pulmonary artery systolic pressure is estimated at 70 millimeters of mercury. The question to you is, in addition to heart failure management with diuretics, which of the following is the best approach to management of her severe TR? A, no surgical consultation. B, surgical consultation for isolated mitral valve replacement. C, surgical consultation for isolated tricuspid valve repair. Or D, surgical consultation for mitral valve replacement and tricuspid valve repair. The intended answer here is A, no surgical consultation. This is a patient with significant tricuspid regurgitation in the setting of a previously repaired mitral valve with profoundly decompensated heart failure in the setting of a presumably ischemic cardiomyopathy with pulmonary hypertension. The initial therapy here is really heart failure optimization to lower pulmonary artery pressure and reduce right ventricular congestion in hopes of reducing the tricuspid regurgitation. So there would be no indication here for primary surgical intervention. Question number 3 is the final question. A 57-year-old man presents with peripheral edema, fatigue, and dyspnea on exertion. He's had diarrhea and occasional flushing for 4 months. On physical examination, he has elevated neck veins at 9 centimeters with a prominent V wave, a parasternal lift with grade 3/6 holosystolic murmur at the left lower sternal border, and moderate lower extremity edema. Echocardiogram reveals normal left ventricular function, but a dilated right ventricle and severe tricuspid regurgitation with flow reversal in the hepatic veins. The tricuspid valve leaflets are thickened and retracted with restricted leaflet motion and incomplete coaptation. A number of echogenic masses are noted in the liver on subcostal views. A 24-hour urine reveals markedly elevated levels of 5-hydroxyindoleacetic acid, and abdominal CT confirms multiple liver masses. Which of the following is the best management strategy? A, treatment of heart failure and referral for mechanical tricuspid valve replacement. B, treatment of heart failure and referral for bioprosthetic tricuspid valve replacement. C, initiation of octreotide and treatment of heart failure followed by referral for bioprosthetic tricuspid valve replacement after clinical stabilization. Or D, initiation of octreotide and treatment of heart failure but no surgical intervention. The answer here is C, initiation of octreotide and treatment of heart failure followed by referral for bioprosthetic tricuspid valve replacement after clinical stabilization. As you will all have recognized, this patient is a patient with likely carcinoid syndrome and severe tricuspid valve regurgitation that is symptomatic. So this patient has features which would suggest the need to treat the carcinoid tumor to suppress the production of these serotonin metabolites, manage the heart failure, and then refer the patient for a bioprosthetic tricuspid valve replacement, which is the treatment of choice for patients with this pathology.